Hello, and welcome from my home in Oklahoma. Not quite New Orleans, but we'll get by for this year. This topic is catheter techniques for pulmonary embolism. I would like to thank Dr. Craig Walker once again for inviting me to speak at NCBH, the Digital Education Series. I've participated in Horizons for a number of years and am always happy to respond to Dr. Walker's request. I like to give kudos to Dr. Jemima Good, who is one of my third-year residents here at our internal medicine residency program, who helped with this slideshow and some of the research for this topic. Disclosures, there are no disclosures. I am not have any honoraria or anything from companies of any devices that will be discussed. So pulmonary embolism. By definition, this is a lodging of a thrombus or other embolic material from a distant site winding up in the pulmonary circulation. It is the third most common cause of death in hospitalized patients. There are approximately 600,000 cases per year, with 100,000 to 180,000 acute pulmonary embolism related deaths. We classify these as low, moderate, and high, and that's what guides our therapy once we've made this diagnosis. Risk classification: low risk is a hemodynamically stable patient, normal right ventricular function, biomarkers, troponin and D-dimers are negative. The mortality for this group of patients is less than 3%, and the treatment is conservative with initial heparin and anticoagulation for 3 months, as well as investigation of the site or source of the embolism. Intermediate risk, which is going to be the predominant group we're talking about today. The RV to LV ratio is increased as defined by CT scan or by echo, and that ratio is greater than 0.9. There'll be an elevated BNP, there'll be possibly an elevated troponin as well. The mortality in this group is 3 to 15%. From my own experience, when a CTA is ordered, many times it is not reported, the RV to LV ratio, and you'll need to call the radiologist to specifically measure that for you. Our hospital does not have 24/7 echo coverage, so we rely on the CT scan, and most of the time I do have to call the radiologist to tell me what that ratio was. In the high risk category, the massive saddle embolism, patients are hypotensive, cardiogenic shock. Many times they're coming in under CPR, which is usually PEA. Mortality for this group is greater than 15%. So once you've made a diagnosis of a pulmonary embolism, using the Pulmonary Embolism Severity Index will help determine, are you going to treat this patient aggressively or conservatively? This uses the age, comorbidities, vital signs, which will give you an estimate of mortality at 30 days. Again, we don't use this before we made the diagnosis of PE, it's after the diagnosis has been made. So what are the treatment options? Like we're talking about with the intermediate or high risk, heparin versus systemic thrombolysis, there is a reduction of recurrent PE or death from 19 to 9.4%. However, the bleeding risk with systemic thrombolysis is 20% of major bleed, 3% intracranial bleed. You have the option of a catheter-directed thrombolysis with ultrasound assistance, or just direct catheter-directed thrombolysis without the ultrasound. Thrombectomy and IVC filter, which is determined after the PE treatment. So catheter-directed thrombolysis with no adjunctive treatment. Much of the data that we have is retrospective. However, major bleeding with catheter-directed thrombolysis is markedly reduced to 2.3%. And in the major studies performed, there was only one case of intracranial bleed, which was at the higher dose of TPA at 4 milligrams an hour, as opposed to the standard that we have used, 2 milligrams per hour. The ultrasound assisted directed thrombolysis, the Optilyze trial, Seattle 2, Optilyze PE, all used an ultrasound assistance, all used directed intra-arterial, in other words, catheter in each pulmonary artery therapies. So in Ultima, USAT was effective as heparin to improving RV functions in patients with intermediate PE. The conclusion was that pulmonary emboli at intermediate risk using a standardized therapy was superior to anticoagulation with heparin alone, especially in reversing the right ventricular dilatation at 24 hours, and there was no increase in bleeding complications. Seattle 2 did show a 25% decrease in CT measured RV to LV ratio. Again, this used a total of 2 milligrams per hour, 1 milligram per artery, but they did have an ultrasound delivery system, and each catheter was placed directly in the right and left pulmonary artery. There was no intracranial hemorrhage with this study. Optilyze is a very busy slide here. Suffice it to say, in the arm that gave a total of 4 milligrams an hour, that was the one incidence of an intracranial bleed. The rest of these were using 2 milligrams per hour. There are thrombectomy devices, which I'm not going to get into because we're talking about catheter-directed thrombolysis, but Angiovac, Penumbra, the flow retriever are all approved devices for PE. There are a number of other devices which have been tried off-label, and because of FDA purposes, I wouldn't say this at the live meeting. I'm not going to say it on the digital education series as well. Thrombectomy techniques. The AngioJet actually has a black box warning from the FDA. The flow retriever, which was for which the FLAIR trial was performed, uses a large catheter, 22 French. Penumbra extract PE, it met safety and efficacy endpoints, but we still don't know the long-term benefits of this as opposed to thrombolysis. Angiovac is a 26 French system. There's a need for perfusionists, so this is a costly program to have, especially if you're a small hospital. In our hospital, I actually will use a pigtail catheter to break the clot up. I'll describe that technique in a couple of slides from now. This only takes an 8 French guide. And lastly, we have surgical embolectomy, and obviously those we save for the massive or submassive PEs on those patients who are markedly compromised. Where should we get access? The right common femoral is the best place to get access when you're going to use directed thrombolysis. In studies performed, this is from 60 to 70% of the time. Left common femoral, 50 to 25%. Again, there's a little bit of difficulty in getting adequate position of your catheters when you're coming from the left. The right IJ approach is used sparingly. My issue with that is if you develop a bleed from your thrombolysis, you can easily have hemostasis and can put pressure on your femoral approaches, not so much on the IJ approach. Some access pearls of wisdom: use your micropuncture and ultrasound to gain access. We all say why, we can always hit the vein, we always get on the first shot. The bottom line is you don't know if there's an active clot in that femoral vein unless you've had an ultrasound that has actually gotten high enough to tell you that, and you're about to give TPA, so you don't want to miss. So you use the ultrasound to help you get access in the femoral vein. Device placement, and again, this is partially my technique. After appropriate sheath is in, now granted, whatever device you're using, like I said, with my technique, it's an 8 French sheath. I place a Swan-Ganz catheter in the PA to get PA pressures with an exchange wire. After I get the PA pressures in my angiogram, I will break up the clot with the pigtail catheter and then place my Swan-Ganz catheter in place. If it's bilateral, you're going to want to do it on both sides. So my outside the box, so that the FDA realizes I'm not selling anything here. It's nothing. Every cath lab doesn't have. After you've done your PA angiogram, use that pigtail to break up and disrupt the thrombus. I place a Swan-Ganz catheter, which is a VIP, which has a RV port. With that RV port, I will infuse the 2 milligrams of TPA an hour so that it gets directly to both sides of the clot in the right and left pulmonary artery. We check cardiac outputs. We check PA pressures. And I'm sorry, there's a misprint there on the 4th bullet point, the 1 milligram per hour each catheter. That is for the selective placement, not for this particular procedure. The advantage of having your cardiac output and PA pressures measured constantly, when that cardiac output improves and that PA pressure improves, you've lysed the clot. You can now say we can stop the TPA. That way you're not giving more than you have to, and it gives you a direct measurement that you have had success. We always follow hemoglobin and hematocrits, fibrinogen levels, and you do have to have blood available because we are giving a thrombolytic. So what can we deduce from the studies? Lower doses have been used with duration of treatment for 24 hours or less, usually much less. We generally see results in 6 to 8 hours. Ultrasound delivery systems versus catheter-directed thrombolysis alone, there has not been any definitive proof that the ultrasound is superior. Does the ultrasound assist reduce ICU time, hospitalization, and cost? Well, it doesn't reduce cost because the catheters are a little pricey. This is unproven to this point. Will infusing TPA, whether in the RV or with an infusion catheter like a Cragg McNamara, a Fountain, or Unifuse, will that be as effective as other available devices? Again, this has not been shown. Should we aspirate the thrombus? Again, that is a pricier piece of equipment. It's a larger bore catheter in the vein. That will be something that an individual hospital will have to decide upon if they want to invest in that technique. So the data is encouraging for catheter-directed thrombolysis in the treatment of intermediate pulmonary embolism. But further study needs to be performed to determine the short and long-term benefits. None of these studies that were done looked at how these patients were a year later. Did we prevent pulmonary hypertension? Did we improve RV function enough to warrant benefit? These are things that will need to be investigated. The randomized trials, again, will need to be performed to determine the role of catheter-directed therapy. Massive pulmonary embolism or high-risk bleeding patient, those should be considered for thrombectomy or the surgical option. These studies, though, have been with limited data. Again, no long-term data. Do we need to place an IVC filter after we've thrombolyzed? It depends if there is still residual thrombus, say in a DVT. And obviously you'd want to put a retrievable filter in so that we don't have the complication of long-term IVC filter. The learning curve on performing this is actually not that steep. It's basically getting PA access from a femoral approach. The cost with using our technique with the Swan-Ganz catheter and pigtail is obviously quite cheap. The other techniques for aspiration is more costly, and more people will need to be available. So it would be a little bit more of a burden on the hospital to have a program such as this, especially for the smaller hospitals. So intermediate massive PE is life-threatening and quality of life threatening. If you're going to enroll into a program or a desire to take care of acute PE with catheter-directed thrombolysis, I feel you should treat these the same as you would treat a STEMI. You have a call team, you're going to come in. If there's no program available at your hospital, you want to transfer these people immediately or consider systemic thrombolysis if there are no contraindications. However, you need to be very frank with families that there is a 3% chance of an intracranial bleed, and they need to understand that ahead of time. Use the Pulmonary Embolism Severity Index once the PE has been diagnosed. This will help you as to your decision tree. Some of the references of our talk here. Now, realizing football isn't going to be widespread. I made this slide before, but the scariest words in Big 12 football, Boomer Center. Thank you again for your time. Hope to see you next year at Horizons in New Orleans.